Welcome back for part 2 of GI elimination. After completing the first steps of the nursing process, it's now time to implement our nursing interventions. A wide-ranging goal for bowel function is that clients will have soft form bowel movements regularly. What are some ways that we can promote regularity and that perfect poop? For patient privacy, when possible, have them mobilized to get up and use the restroom. If the client is on bed rest, ensure that the curtains are pulled. You can use a bath blanket. Make sure you turn away and excuse any visitors from the room. The client's position should be semi-Fowlers to a full Fowlers. Ensure they're positioned correctly on the bedpan. However, the best option is getting up and going to the bathroom or using the bedside commode. Not only does this allow for proper positioning, but also promotes physical activity. Because eating stimulates peristalsis, offering toileting after meals is beneficial. Encourage clients not to wait or ignore the urge when they need to use the restroom. Try to follow a person's normal bowel habit routine as closely as possible. As providers, we can also encourage adequate fluid intake. Remember, we need about 1,500 to 2,000 mLs of fluid per day to keep stool soft and to aid in the production of mucus to lubricate the colon. Along with adequate fluids, a diet higher in fiber is recommended. This includes items such as carrots, beans, broccoli, apples, strawberries, and whole grains. Raw fruits and vegetables are best. Physical activity or exercise is encouraged 3 to 5 times a week, or range of motion exercises for clients on bed rest. For further information on promoting healthy bowel movements, see the embedded video on this slide. Diarrhea and constipation are common diagnoses of the GI tract. Let's take a closer look. Starting with diarrhea, it's important to recognize and identify the cause. This could be contaminated food, a viral infection, dietary changes, side effects of medications or other dietary supplements, psychosocial or behavioral factors such as taking laxatives for weight loss or other life stressors. Preventative measures for diarrhea include hand washing, avoiding a high-fat or high-spice diet, along with avoiding other greasy foods. Plain yogurt and other probiotic foods can be beneficial. Proper food preparation can also play a key role. As the nurse, you must also monitor your client. Monitoring stools to quantify diarrhea. This is where we're looking at our frequency, amount, color, and consistency of stools. Assessing and monitoring for fluid imbalance. As the nurse, we will monitor intake and output, body weight, and vital signs to assess hydration. Also assess skin turgor and the moistness of mucous membranes. We also want to monitor for alterations in perineal skin integrity. Clients with diarrhea may experience perineal irritation and excoriation. The main treatment for diarrhea is proper diet and fluid replacement. Clients may begin on a clear liquid diet and then progress to a BRAT diet. A BRAT diet is acronym for bananas, rice, applesauce, and toast. This diet allows for GI rest and reduces the amount of stool produced. Other options would be to reduce the fiber in the diet, as we know fiber promotes peristalsis. Avoid sudden large intakes of fluid or food when resuming a diet, as this may trigger mass peristalsis. Medications are usually reserved for chronic diarrhea or when there is a known cause, such as chemotherapy. Avoid using medications that slow peristalsis. If it's an infectious process, such as C. diff or food poisoning, an increase in motility actually helps eliminate the causative factor. Clients with persistent bowel incontinence and frequent loose stools require special nursing care to prevent impaired skin integrity because of the moisture and activity of the enzymes in the stool. For continued incontinence, there are devices available. First, there's an external fecal collection device. You may apply an external fecal incontinence pouch to protect perianal skin or to collect a large fecal sample. This is a common approach for clients with uncontrolled diarrhea. The pouch collects fecal drainage, keeping feces away from the skin. Pouch systems vary widely, and the equipment is similar to those used for patients with an ostomy. Indwelling fecal drainage devices, like seen in the picture below, are used to collect liquid stool from bedbound or immobilized ill patients. They consist of a soft, latex-free catheter and a collection bag. The tube is inserted into the rectum, and a balloon on the end is filled with saline or water, much like a Foley. A common intervention for bowel incontinence is a planned bowel training program. This will help establish a healthy bowel regimen. Okay, moving on to nursing considerations with constipation. Clients most likely to experience constipation are those who have decreased activity, are on bed rest, are receiving opioids or other medications that slow peristalsis, have decreased fiber and fluid intake, or post-op or post-anesthesia. For prevention of constipation, please refer back to the slide and video regarding promoting regular defecation. Now, with monitoring our clients with constipation, be sure to assess for anal fissures or hemorrhoids, rectal ulcers, fecal seepage, and skin integrity. If your client reports severe abdominal pain, be sure to pay close attention. This could indicate complications such as impaction, obstruction, a volvulus, or potentially even a bowel perforation. Treatment for constipation includes an increase in fluid intake, an increased intake of high fiber foods, increased physical activity, promoting privacy when toileting, allowing for uninterrupted time to use the toilet, especially after meals when most peristalsis occurs. Medications can also be used to treat constipation. There are bulking agents such as Metamucil or laxatives. However, habitual laxative use can cause dependence and should be avoided long term. A complication of constipation is fecal impaction. This is a presence of a hardened fecal mass in the rectum. Liquid stool may seep around the hardened mass. Patients often report feelings of fullness, bloating, constipation, diminished appetite, and a change in bowel habits. For severe constipation or impaction, enemas may be ordered by the physician. There are multiple types of enemas to be given. A cleansing enema promotes removal of feces from the colon. These cleansing enemas can be given either high or low. If they are given high, a client receives the initial installation of fluid in the left lateral position, then moves to a dorsal recumbent, and then the right lateral position for the remainder of the installation. This turning process allows fluid to follow the shape of the large intestine. However, this does create more risk for fluid and electrolyte imbalance as a larger surface area of bowel is impacted. A low cleansing enema is the most common. A client with a low cleansing enema receives installation of the enema in the left lateral position and remains in that position throughout. Cleansing enemas are also categorized by hypotonic, hypertonic, or isotonic. Today we'll discuss hypotonic and hypertonic cleansing enemas. Hypotonic enemas are larger volume, about 500 to 1,000 mL of saline or tap water with some Castile soap. These are often called a soap suds enema. They work by distending the colon to get a rapid evacuation of stool, as this stimulates peristalsis. Hypertonic enemas are usually smaller volume, about 90 to 120 mL of a hypertonic solution like sodium phosphate that draws water into the bowel, causing distension and stimulating peristalsis that way. These enemas are rapid acting, and a bowel movement usually occurs between 5 and 10 minutes. You may have heard of Fleet's enemas, as you can mostly get these over the counter at any of your drugstores. Hypertonic solutions may be contraindicated, though, in renal failure or CHF because of the adverse effects of the sodium retention. Another category of enemas are retention enemas. Retention enemas introduce a solution into the colon that is meant to be retained for a prolonged period of time. Consequently, the volume is small, usually about 90 to 120 mLs. The most common retention enema is an oil retention enema. This type of enema instills oil into the rectum to soften stool and lubricate the rectum. This type of enema may be used to assist a client to pass a hard stool or before digital removal of stool. Key points when giving the enemas are to ensure your patient is lying in the Sims position. Ensure that the fluid temperature is lukewarm. When you insert the enema, aim for the umbilicus. Lubricate and insert about 3 to 4 inches for an adult. Make sure you have the bedpan or bedside commode ready to go. And if using a bucket or a bag, raise the level of the container with the fluid 12 to 18 inches above the hips max. For more specifics on enemas and their actions, refer to your chart on page 1026 in your text. After failed enemas and other treatments, the physician may order for digital removal of stool. Digital removal of stool is accomplished by breaking up the hardened mass into pieces and manually extracting the pieces. You may administer an oil retention enema at least 30 minutes before digital removal to soften the stool and decrease the client's discomfort during the procedure. Have the patient lie on their left side, and a lubricated finger is placed into the rectum and moved along the border of the rectum to loosen the mass of stool and help facilitate the removal. This is a serious procedure as it can stimulate the vagal nerve reaction and cause bradycardia. Ensure you have a baseline set of vital signs before you start. Patients with a history of heart disease or dysrhythmias are at greater risk.